Hello, and welcome to our virtual webcast, Practical Perspectives on Rapid Change in Endometrial and Cervical Cancer Management, Exploring Innovative Therapy in Gynecologic Malignancies. During this event, we'll explore how recent evidence has changed our approach to managing a variety of endometrial and cervical cancer patients and disease subtypes. I'm Dr. Linda Duska, and I'm so pleased to welcome my colleagues and experts in the field, Dr. Shannon Weston and Dr. Trey Leith, to join me in this panel discussion. So let's get started. What we'll cover tonight is listed on this slide. We're going to discuss the implications of recent clinical trial data in endometrial cancer and how to use immunotherapy and targeted options in this disease. We'll understand where newer therapeutic options fit in cervical cancer and how to move beyond chemotherapy. And then we'll present some patient cases and take questions from the audience. And I'm just going to start us off with some statistics. So on the left-hand side of the slide, you'll see the survival statistics for endometrial cancer. And you'll note that the percentage of women who survive 5 years is a little over 80% in the United States. This is primarily because women are most often diagnosed with early stage disease. But you'll also note the less than 20% 5-year survival for women with distant disease. And also those women who experience recurrent disease have very low response rates to subsequent therapy. It is for these populations that new treatments are needed. Similarly, and perhaps a bit worse, in the setting of cervical cancer, while the numbers in the United States are lower, the percentage of women surviving 5 years is also lower at 66%. And this is also a population, particularly in the locally advanced cervical cancer, recurrent and advanced cervical cancer patients, where new therapies are needed. In addition to this, in endometrial cancer, we've seen a significant increase in the United States in both incidence and death rates, in contrast to other solid tumors. This is probably multifactorial, but I want to also point out that there are some disparities here, in particular for Black women, where the incidence and the death rates have increased disproportionately to the overall population. Similarly, in cervical cancer in the United States, despite a robust screening program and increased uptake of the HPV vaccine, we still see disproportionate numbers of women with locally advanced cervical cancer in the states in the dark blue on the left. You'll also note that there are certain very vulnerable populations to cervical cancer, in particular, racial and ethnic minorities, socioeconomically disadvantaged groups, and women residing in rural and isolated areas. These are the women who need these newer therapies that we're going to discuss tonight. So let's start with endometrial cancer, and Dr. Weston is going to take us through that data. And I'm just going to start us off with 2 slides. The first are the Nccn Guidelines that are shown on this slide. For recurrent or metastatic disease, the primary chemotherapy regimen is carboplatin and paclitaxel, which was established by GOG 209, a non-inferiority trial that is shown on the right upper hand of this slide, and established paclitaxel and carboplatin as the standard of care. Additionally, you'll note the addition of trastuzumab for stage 3 or 4 or recurrent HER2-positive uterine serous carcinoma. This recommendation was based on progression-free survival data that was originally presented by Dr. Fader and her colleagues in 2018. At SGO this year, Dr. Fader updated those data, shown in the lower right-hand corner of the slide, to include an overall survival advantage for the inclusion of trastuzumab in women with uterine papillary serous carcinoma that is HER2 positive. Additionally, in the bottom of the slide, you'll note the addition of pembrolizumab, and Dr. Weston will discuss that further. Finally, I just want to briefly mention the molecular classification of endometrial cancer shown on this slide that is changing the way we think about and approach endometrial cancer. Instead of the traditional type 1 and type 2 categories that we've always thought of, we're now moving into a molecular classification that helps us better characterize women's tumors, is more reproducible than the traditional histology, and can allow us to target therapy and actually even in some cases predict prognosis. You'll note on this slide the so-called hot tumors, the ultra-mutated Poli or hypermutated MSI tumors are on the left. These are the tumors with high mutational burden that we would expect to be responsive to immunotherapy. And Dr. Weston will talk to us more about those. On the right-hand side of the slide are the so-called cold tumors, the copy number low, which include the majority of endometrioid tumors, and the copy number high, which include the uterine papillary serous carcinomas, as well as about 25% of the grade 3 endometrioid tumors. These are also tumors that are very difficult to treat, these copy number high tumors, and tumors that are in need of targeted therapy. So with that, I'm going to move us on to challenging the status quo in endometrial cancer and introduce Dr. Shannon Weston.
Thanks so much, Linda. It's great to be here with all of you. Sorry we can't be in person this year, but I'm going to spend the next few minutes just taking us through a little bit of what's been done over the last year to challenge the status quo in endometrial cancer, both along immunotherapy as well as targeted options for care. But first, a little bit of history. You know, we have been able to explore the use of chemotherapy as a single agent and in combination for endometrial cancer across a number of different studies, and the GOG 129 series was one. And in what we found is, regardless of the chemotherapy agent, the majority have response rates that are going to be less than 15%. Really, the only kind of interesting single agent chemotherapy was paclitaxel, where we saw a response rate of about 25%, which was certainly interesting. And so that brought us into the 229 series, where we were exploring targeted agents, specifically a lot of anti-angiogenic agents as well as some others. And you can see here that across all of the different 229, we went from B all the way down to O. You can see that overall, the progression-free survival that any of these agents provided was really nothing more than 3. Really, bevacizumab and temsirolimus approached 6, but there was quite a bit of toxicity. And only bevacizumab, aflibercept, brivitinib, and cediranib really met kind of the bar for future study and future control arms. So let's talk a little bit more about how we can be more targeted, because these anti-angiogenics don't necessarily specifically target endometrial cancer. So we've known that those hot tumors that Dr. Duska was just talking about have a lot of interest in and could potentially benefit from the use of checkpoint inhibitors, specifically anti-PD-1 or anti-PD-L1 antibodies. The KEYNOTE-028 study was focused on PD-L1 positive endometrial cancer, and we can see that there was a response rate of about 13%. Not much better than what we see with chemotherapy in general, but certainly a more interesting, more targeted option. But I want to call your attention to the proportion of patients that also had prolonged stable disease, 13%. So that gets us about 26% of patients with tumors that had PD-L1 positivity that had some sort of benefit. But even more interestingly are the MSI high tumors. So Keynote 158 focused on that group. And specifically in the endometrial cancer population, we saw 57% response rate. So much more interesting, much more exciting. And it seems that for at least endometrial cancer, the MSI high marker is a better one when we're selecting the type of immunotherapy. But that brings us to Garnet. So Garnet was a study of single agent dostarlimab, another PD-1 inhibitor that was focused on both types of endometrial cancer, not just MSI high, but also the microsatellite stable group. And this particular table shows you the response rates across the different groups. And then I'm going to focus a little bit on some updated data. So these were data that were presented back at the Society of Gynecologic Oncology in 2019 that demonstrated, again, a high response rate in that MSI high group of almost 50%. But interestingly, in the microsatellite stable group, there was a 20% response rate. So this was rather unexpected. Now, we have not seen these data be updated, so it'll be interesting over the next year to see if these data hold up. What we did see was an update of the Garnet trial for the microsatellite instable or the mismatch repair deficient group of endometrial cancer. And this was, again, a single agent study of dostarlimab. And the updated data revealed a 42% response rate. So still very impressive. And I want to call your attention over to the waterfall plot. Now, of course, with the waterfall plot, we want to see things falling. You can see the large proportion of patients had a reduction in disease, even if it didn't meet the pre-specified, less than or a reduction of 30% in disease. And you had an additional maybe 16% that had a stable disease. So really an interesting amount of clinical benefit for this drug for endometrial cancer. And importantly, it was durable. So these swimmer plots show the duration of response. It really has not yet been reached for those tumors that are microsatellite instability high. So it'll be very interesting as time goes on to see where people really land here, because this would indicate that the progression-free survival is going to be much higher than those prior studies that I showed you. And of course, if we're going to keep patients on something for a long time, we want to make sure that it's safe. This shows that, in general, the side effects for dostarlimab are very similar to the other checkpoint inhibitors. We see, as far as grade 3, 4 adverse events are concerned, diarrhea, colitis, transaminases increased, very rare pancreatitis and the like. But importantly, only 2% of patients discontinued due to adverse events. And that's very important and indicative of the tolerability of this treatment. But what can we do better? Now, we know if we look on the left side of this schematic, there are some limitations to the use of PD-1 or PD-L1 blockade. We can see relapses and recurrence. We're not really great at how we predict who responds. And there is a whole population that doesn't necessarily garner benefit from the single agent immune checkpoint inhibition. And so the idea around combinations, whether that be with chemotherapy, radiotherapy, or targeted therapy, is to really increase the activity of that immune system to promote the presentation of tumor antigens, increase the infiltration of T cells, enhance the immunogenicity of the tumor cells, and really get us better results, not only in the population we expect to benefit, the microsatellite instability high, but also potentially in those microsatellite stable groups. So that leads us to Keynote 146, which was a combination trial of lenvatinib with pembrolizumab that was published and presented by Vicky Macker at a number of different venues and really showed some impressive results. And the patients get the lenvatinib every day orally and the pembrolizumab every 3 weeks. And this was given in a group of unselected endometrial cancer. The majority of the patients actually were microsatellite stable. And here's that ever popular waterfall plot where we saw really an amazing response rate. And if you look, the majority of the patients had some kind of tumor shrinkage. And so, of course, that's very exciting. But when you tease out the cell types, this particular waterfall plot has the cell types where you can see it wasn't just in the endometrioid tumors, but also clear cell and serous tumors benefited from the combination of these two drugs. And when you look at duration of response and progression-free survival, it really is quite impressive. Of course, the tumors that do have microsatellite instability high still get quite a bit of benefit from the combination. But impressively, those tumors that are microsatellite stable also get quite a degree of benefit that is durable. And this is just demonstrating overall survival. So again, the best survival is going to be in that patient population that is have tumors that are microsatellite instability high. But still, those patients that were treated with the combination do have an impressive median overall survival. And whenever we're talking about keeping patients again on for long term, safety is important. And I think those of us who have prescribed this combination know there are some side effects that must be mitigated. And, upwards of 64% of patients will need a dose reduction due to adverse events on this combination. But importantly, only about 18% ultimately will discontinue. So it just really advocates for making sure that you're communicating with your patient about the potential adverse events, trying to address them early and really find that sweet spot dosing for your patient so she can get the best benefit. Now, just one additional analysis that was presented this year at ASCO, which was quite interesting, was a post hoc analysis that tried to tease out the groups that got lenvatinib and pembrolizumab. And again, this was previously treated endometrial cancer. Subgroup 1 had only one prior line of cytotoxic therapy, and it didn't matter the surgical stage or the setting. They could have gotten an adjuvant for their local regional disease or in treatment for metastatic disease. And conversely, subgroup 2 was only local regional at diagnosis and only received adjuvant cytotoxic therapy, so no treatment for metastatic disease. And you can see that nice response rate is retained across both groups. But importantly, that second group where it's more of their first recurrence is being treated with this combination, they seem to garner the most benefit with a 57% response rate and a duration of response that has not yet been reached. And here's just the waterfall plots from that post hoc analysis. You can see the majority of patients had received some prior therapy for their recurrent disease. But again, in that group that had never had any treatment for their recurrent disease, almost every single patient had reduction of disease and almost every single patient had objective response. So pretty impressive. Now, what about other combinations? So, the combination of targeted therapy with immunotherapy is certainly interesting. This is a study that the Big Ten Cancer Research Consortium did that combined pembrolizumab with paclitaxel and carboplatin, so a standard chemotherapy regimen. And the patients were advanced or recurrent endometrial cancer, had measurable disease, and less than or equal to one previous systemic therapy, and were treated with 6 cycles of chemotherapy with pembrolizumab. And you can see here that there were about 40 patients that were treated, and the response rates was 74%, which is much above what we would expect for chemotherapy alone. So certainly a very exciting bit of data, small study, but still kind of exploratory and thought-provoking. Interestingly, they did start to tease out the progression-free survival in the group that was mismatch repair deficient versus mismatch repair proficient. And again, it does seem that the group that has mismatch repair deficiency has the most benefit from this combination. When we talk about adverse events, we see that 100% of patients had some type of adverse event, but serious adverse events was limited to about 20% of patients. So seems to be tolerable. Only 10% of patients had to discontinue the treatment. So it does seem to be an option to combine, and there are a number of different studies now that are combining chemotherapy with immune checkpoint inhibition in the upfront setting. So it'll be interesting to see as all of those read out. And then finally, this was a study that really caught my eye because it's really kind of going into a completely different direction. We've talked a lot about studies that are across all endometrial cancer and not really selecting out, to Dr. Jessica's point, those cold and hot tumors, not really selecting out the types that we've identified with the TCGA. So this was a study that looked at WEE1 inhibition. It was specifically in uterine serous carcinoma, and that has to do with the proportion of patients that have p53 mutation on which this particular drug is expected to act. And you can see here that there was a really nice response rate of almost 28% in a uterine serous population that had had multiple prior therapies. And so this is certainly very interesting. It's a small study, but it's very compelling, and we'll be very interested to see how things move forward with it. This is just showing you of those patients that did respond. Again, those swimmer plots on the left and the spider plots on the right show that these were durable and deep responses. And some patients stayed on these therapies for more than 12 months. And so that's well beyond what we would expect in this population, and certainly very exciting, but does bring up the idea, and I think we'll get into this in some of the cases, and if this particular drug were to go forward, how would you sequence this? Would you do lenvatinib pembrolizumab first, followed by, say, adavosertib? So it'll be very exciting as these drugs continue to move forward. And if we're going to use it, how bad is the adverse events? In general, adavosertib is tolerable, but about 50% of patients did require some kind of dose reduction. Only 5% discontinued due to adverse events. And this drug, it's a new drug, so it's important to kind of touch on some of the side effects. We see things like diarrhea, fatigue. It does affect the count, so you can see anemia, thrombocytopenia, neutropenia. And so although tolerable, it does sometimes need some dose adjustments to be able to get the patient to the right level. So with that, I think we're going to talk about some cases, and hopefully we'll get into some discussion of these results.
So that was some really interesting options for our patients, and particularly the keynote subset analysis that you talked about from ASCO almost suggests that you could consider using lenvatinib and pembro as first line rather than Taxol carboplatin. What do you think about that?
Yeah, I think it's a really exciting option. And I think the opportunity to defer chemotherapy is always something our patients are asking about. The keynote 775 trial is going to look at that. It's directly comparing lenvatinib and pembrolizumab to chemotherapy. So I think it'll be really interesting to see the results there.
So are you guys ready to talk about some cases?
Yeah,
let's do it.
Definitely.
Great. So let's start with this first one. And I'm not going to read every single word, but basically 48-year-old woman, FIGO grade 1, endometrioid cancer, has a minimally invasive hysterectomy, BSO, and sentinel nodes, has a stage 1B grade 2 as her final pathology, and IHC done routinely reveals loss of expression of MLH1 and PMS2, and subsequent testing shows MLH1 promoter methylation, hypermethylation was present, and she was treated with vaginal brachytherapy alone. 1 year later, she presents with recurrent disease by pelvic exam and CT. It's confined to the pelvis, no other disease is seen, and a biopsy confirms recurrence. So can we talk about what you would offer her at this point?
Yeah, I mean, I'm happy to start. I think that it's been about a year since she was treated, and the standard of care definitely is chemotherapy in this situation. Paclitaxel and carboplatin would be on the discussion. I think many of us have one or more of the really exciting trials that are available right now for upfront endometrial cancer. So I definitely would try to recruit her for one of those trials that are including, chemotherapy with either a checkpoint inhibitor or checkpoint inhibitor and a PARP inhibitor. So we've got a lot of really exciting options to try to, maximize treatment here.
Thanks for the pitch for the clinical trials. Completely agree. I think all of these, actually, I'm really glad you did that. I think all of these patients should be offered a clinical trial if one is available. That's my bias as well.
And Shannon, I completely agree with you. I think the standard treatment is going to be chemotherapy. Although these are the frustrating cases we see. We see a patient that has what appears to be a low-grade, low-stage tumor. Yeah. We discuss the pros and cons of adjuvant therapy. Some patients elect to proceed with that. Some don't. And I think in either case, patients are feeling pretty confident that their disease will be controlled. And then unfortunately, we do see these patients that unfortunately have, a recurrence, and in this case, relatively early. And I would make it a trifecta that, yeah, clinical trials are really the best way to go here for patients that are otherwise eligible.
We haven't talked about hormones, but in this particular disease, hormones tend to be pretty active. What do you guys think? Let's say she was older or more infirm and declined chemotherapy. Would hormones be an option for her?
Yeah, oh, absolutely. I mean, I think there's a couple of different hormonal options for this particular patient. Endometrioid gives us a lot of options from that standpoint. You could do alternating tamoxifen with megestrol acetate, and that really, I mean, that's a fairly easy regimen to tolerate. They, all they have to do is remember switch the pills every 3 weeks,
yeah,
which can be tricky. But other than that, they tend to tolerate really well. I mean, I think for this patient population, you can often move through these different options. And so, which one first is always kind of a discussion, but it all depends on the patient. But I've even, used that after chemotherapy and had some success for a patient that just wants a break off, say, paclitaxel. So that's definitely something that can be done.
Well, let's go that way. She's treated. You give her carboplatin and paclitaxel, initially with a good response, but then develops new symptoms. Her pelvic pain comes back, essentially, following cycle 6, and CT scan now confirms disease progression. How would you treat her now? And let's assume, obviously, we're going to pitch a clinical trial, but if we don't have one, what would you offer her?
Dr. Leith, you want to take one?
Yeah, no, I'd be glad to do that, Shannon. So, I think for patients like this, we tend to go ahead and collect NGS testing. Now, again, that may or may not lead to a clinical trial, but as directed from our chair, Dr. Duska, we don't have a clinical trial to offer her.
Oh, sorry. Well, don't forget she's hypermethylated.
Yes,
so we do have that.
Yes, we do.
Usually we will look at, the role of immunotherapy for those patients that have mismatch repair deficiencies. We've tended to utilize pembrolizumab just based on the earlier status of its approval. However, the combination that Dr. Weston has so eloquently discussed today with lenvatinib and pembrolizumab is certainly another common consideration for these patients. The fact that she is 48, young, likely healthy, we would discuss that as an option with her and likely proceed with some type of immunotherapy. Just because, although, again, we've seen a lot of exciting response rates, they're not as good as we want them to be. As you all know, these responses can be very durable for patients. And that's very exciting with these agents and really things that we really didn't see as much with chemotherapy.
Well, you brought up next generation sequencing. So let's just touch on that because across the US, practice varies about who uses next generation sequencing and when and how we get it paid for. Some of us, and I think if this applies to Dr. Weston, are able to do it in-house. Most of us are not. And so do we think that next generation sequencing should be standard of care at this point in disease? What do you think about that?
Yeah, I mean, I really do. Now, again, I must admit I have biases about that because we are able to get it covered not only with in-house testing, but also with some in-house funding and clinical trials that our dean has allowed us to pursue in terms of patients that may not have insurance coverage to be able to get that testing. I think it does allow us to identify patients that may benefit for mutation-based therapy, which we know is ongoing through a series of large clinical trials. The MATCH trial through the NCI, the TAPER trial, through ASCO, and other targeted therapies, which when we have utilized standard cytotoxic chemotherapy, or in this disease group, immunotherapy, often allow patients to receive agents that they otherwise would not. So I really do consider it the standard of care in the recurrent setting, but it's still a challenge for some patients, although we've been pretty fortunate with our ability to get it covered.
Dr. Weston, what's your opinion about that?
Yeah, I mean, I would echo that. We use it quite a bit, and really, it's so nice to be able to offer something that's more targeted. I think we're still in the infancy as far as endometrial cancer and approvals in regards to drugs with NGS. Certainly on the ovarian cancer side, it's a lot easier because we've got things like PARP inhibition that have, a companion diagnostic approval. But with that being said, as we're gaining more and more information, we know that arguably, endometrial cancer is the most aberrant of all of the solid tumors. And so you're going to potentially find targets, and then you can place these patients onto treatments based on the targets you identify. And so it seems like a very high yield thing, especially as more and more, for example, Joyce Liu's data around adavosertib, and, knowing that your patient potentially has a P53 mutation, and getting that patient onto that type of trial would be essential.
Well, this patient fortunately had a good response on dostarlimab on a clinical trial, even though I told you we didn't have any for her. Let's move on. In the interest of time, let's move on to the next one. This is now a 60-year-old woman who's diagnosed with serous cancer by biopsy, has surgery with removal of enlarged pelvic and parotid nodes, and has a stage 3C2 serous adenocarcinoma. This one is microsatellite stable and has amplification of HER2. And the plan is made for 6 cycles of chemotherapy followed by tumor-directed radiation, which ultimately she decides not to have because she's just too debilitated by all the chemotherapy, and subsequently has progression, not surprisingly, with this disease histology 3 months later. Again, is there a role for NGS here? I think we decided that there was. And how would you, Dr. Weston, how would you treat her now?
Yeah, I mean, I think in an ideal situation, this is a patient that would really potentially benefit from lenvatinib and pembrolizumab. When you look at Dr. Macker's data, that response rate of about 42% is actually held up in the serous tumors as well. So it does seem to be across all the cell types. But if she was really debilitated after chemotherapy and radiotherapy, you'd really have to be cautious with that and make sure that you get her, mentally ready for the potential side effects that we can see with that combination. This might be a patient you start a little lower dose, to try to eke up. You might just need to be ready to go and do what you need to do. But I do think that is the highest yield. With that being said, that HER2 amplification that we didn't really act on, there's not a lot of standard of care options, but there are a ton of new novel agents that are targeting that aberration that would be really enticing, that might be easy for her to tolerate.
Dr. Leith, anything to add?
No, I would completely agree. And again, I think this highlights several of the issues, the role of NGS in helping to guide therapy, the consideration and really the exciting data from Dr. Fader about the role of, the combination of trastuzumab with chemotherapy for these patients. And the fact that even though we do have these very active therapies, there are patients, certainly with endometrial cancer, that it may be difficult to get through their adjuvant therapy. And so because of that, we do have to, really consider the agents that we're going to recommend. Clearly hormonal therapy, not nearly as active in this group of patients, but, we just should consider the options that are there.
Just to be a tiny bit provocative here, in this case, you wouldn't necessarily need next generation sequencing. Most centers can do testing for HER2 amplification in-house. It's a very common test in breast cancer, for example. And pembrolizumab lenvatinib doesn't require NGS testing, and in serous cancers anyway, has a very high response rate. So it would be possible to proceed with treatment for her with pembrolizumab without NGS.
And again, I think what many of our centers are doing is for patients with advanced stage uterine papillary serous carcinomas, they're going ahead and doing the HER2 testing with their primary path. And so
that's right.
we should have that information for most. And then obviously for patients that have a lower stage tumor that the testing was not performed, again, they're pretty receptive to then proceeding with that testing in the recurrent setting.
Really good point. Thank you for making that point. A lot of places are doing it routinely now based on Dr. Fader's data. Thank you for making that point. And on that note, I'm going to have you move on to cervical cancer. So take it.
Great. Thanks, Linda. Thanks, Shannon. It's a joy to be with you all this evening. Again, I think we would all much prefer to see each other in person in Chicago, but this is a pretty good venue to go through things. So I think a lot of what Dr. Weston noted in terms of looking at therapeutic options for endometrial cancer really apply to cervical cancer as well. We've really learned a lot about how to treat this disease, but unfortunately, as Dr. Duska noted earlier, this really affects minority populations, individuals that are disenfranchised, individuals that are socioeconomically challenged. And because of that, although with early stage disease, we're able to do very well in terms of controlling disease for a prolonged period of time, both in the locally advanced setting as well as the recurrent setting, we certainly have much more of an uphill battle. The NCI's clinical alert greater than 20 years ago about the role of chemotherapy and chemoradiation is one that is still very exciting for us, I think, as GYN oncologists. And most of us still tend to use cisplatin-based chemoradiation therapy. There are some patients that perhaps you'll end up using carboplatin, and cisplatin and 5-fluorouracil really doesn't reach that much of the population, but another potential option. When we think about cervical cancer, I think there's a lot of excitement about immunotherapy in general, and looking at the potential of combining these therapies with our traditional therapies, be it chemoradiation therapy as depicted in this slide, or with chemotherapy in the recurrent setting. Dr. Jyoti Mahadev has done a lot of research on behalf of NRG Oncology, formerly the GOG, really looking at sequencing different types of immunotherapy agents with chemoradiation in women with locally advanced cervical cancer. And again, recently had a publication looking at the role of this in women with para-aortic nodal positive disease. This was some of Dr. Duska's work from SGO earlier this year. And I think this is, again, a very exciting approach that we're all looking at, is really trying to incorporate immunotherapy into the management of cervical cancer, not only in the primary setting for women with locally advanced disease, but as noted again a moment ago, in the recurrent setting. So in this study, patients with locally advanced disease, which included node positive disease with early stage disease, or the patients that had more traditional staging, 1B2 through 4A, with the previous FIGO staging criteria from 2009, were randomized in a 1-to-1 fashion to receive standard chemoradiotherapy with single agent platinum, as we usually do, followed by a consolidation or a maintenance pembrolizumab, versus actually incorporating pembrolizumab during the chemoradiation therapy. And so that's a very exciting approach to getting a new agent into primary therapy, because we all know if we can decrease the risk of recurrence, keep women in remission longer, cure more women, then the agents in the recurrent setting will have somewhat of a lower importance. Dr. Weston really did a great job of commenting on the fact that while we're really excited about some of these newer therapies that are not in the traditional cytotoxic chemotherapy realm, we really do need to concentrate on the role and the potential impact of safety. And I think what Dr. Duska's data showed is that the administration of pembrolizumab in these patients appears to be pretty safe. A lot of low-grade toxicity, which we would expect with chemoradiation therapy alone. But I think importantly, on the far right, we really are not seeing significant dose-limiting toxicity, which would be a concern when we're moving newer therapies earlier into the disease course and management. So when we think about recurrent or metastatic cervical cancer, these are patients that are very challenging to treat. Dr. Tawari presented his data from GOG 240 several years ago, and that was published initially in the New England Journal and subsequently in Lancet Oncology, in Lancet, where this survival curve is taken from. And although the combination of chemotherapy with bevacizumab did improve overall survival from a statistically significant standpoint, we're really not seeing significant long-term durability. And so I think while most of us are incorporating this triplet therapy into the management of patients with recurrent or metastatic cervical cancer, there's certainly a lot more to be done based on the fact that unfortunately, many of these patients will have ultimate progression on their disease. From a second line standpoint, pembrolizumab has been approved based on PD-L1 positivity. And we'll certainly talk about that now. Looking at women with cervical cancer, included nearly 100 women that were receiving the standard dose of pembrolizumab of 200 milligrams every 3 weeks, up to 2 years. And this included tumor imaging about every 3 cycles. Again, these women tend to have a pretty good performance status and had evidence of measurable disease. And when we look at, again, both the swimmers plots and the waterfall plots, although the response rates that we're seeing here perhaps are not as profound as what Dr. Weston was describing in endometrial cancer, I think it really is important to remember that in recurrent cervical cancer after primary cytotoxic chemotherapy, we really do not have any great therapies. And some publications have suggested response rates in these populations under 10%. So although, the overall response rates might be somewhat muted, I think it's very important to look at the top couple of lanes in the far left in the swimmer's plot, and then also looking at the proportion of patients that actually have pretty significant decrease in their visible or their measurable tumor. Taking this a slightly different fashion, looking at combination immunotherapy, Dr. Naumann, and I believe this was actually presented by Dr. Oknen at ESMO, looked at combination immunotherapy. So combining 2 different approaches with nivolumab and ipilimumab, again, looking at 2 different doses. Patients with squamous cell carcinoma were randomized between the 2 arms, and their performance status, again, similar to the Keynote study, also was good with less than 100 patients accrued. I think this is pretty important in that when we see that patients had not received prior chemotherapy, we're seeing a pretty profound response, especially on the left, between the patient, or as compared to patients rather, that had previously received prior systemic therapy. And so I think this really gets to Dr. Duska's point about, perhaps we should be looking at these immunotherapy approaches earlier on rather than just the traditional cytotoxic chemotherapy, again, followed by these. So it's pretty exciting to see that, we're seeing what looks like a better response for individuals that are treatment naive. And we saw that to a similar degree in that the median responses were not reached in terms of a 95% confidence interval. Likewise, progression-free survivals varied, but we saw still that individuals that were treatment naive tended to respond better to this combination of immunotherapy. Not surprisingly, most patients had some toxicity, and although we did see a fair number of patients with grade 3 and grade 4 toxicities, for the most part, what we saw in the combination A with the higher dose of nivolumab is that a relatively small proportion of women had to discontinue their therapy secondary to these adverse events, whereas that was a bit higher in the combo B arm, where patients had a higher dose of ipilimumab, although there's a couple of potential explanations for that, including perhaps longer treatment on that regimen. I think it's also important to note that these individuals did not experience any treatment-related deaths. Looking at other therapies that are out there, Tesotumab Vadoten, which is a antibody-drug combination, or antibody-drug conjugate rather, is a pretty exciting drug that's in development. The payload actually disrupts the microtubules and has been evaluated in a series of clinical trials in women that have generally received both cytotoxic chemotherapy and other therapies for the recurrent cervical cancer setting. In the phase 1 TV201 trial, we saw response rates greater than 22%. And again, I would remind the audience that traditionally these are patients whose response rates may be less than 10% in several published reviews. So it's pretty exciting to see not only a response rate, but also the fact that their median duration of response was around 6 months. Likewise, looking at the assessments, both by the investigators and by the blinded radiologist, we saw pretty similar outcomes in that although there were response rates around 20%, most of the patients had a partial response. Although one patient in the blinded review was noted to have what appeared to be a complete response. And we also had nearly 40% of patients in both arms, 40% of patients in both assessments that actually had stable disease, which again can be quite meaningful for these patients. Looking again both at the swimmer's plots and the waterfall plots, we see that a larger proportion of patients responded, which is pretty exciting. And we actually have a very nice figure here for the manuscript showing patients that have visible disease that's measurable, RECIST criteria that continue to shrink. I think we all know in these patients with recurrent cervical cancer that we take care of, it can be very challenging radiographically to figure out what's going on, as most have already previously received pelvic radiotherapy. GOG 265, I was fortunate enough to present this data several years ago on behalf of the GOG and the NRG, and we hope that this manuscript should be in press relatively soon. Dr. Warner Huh was the PI of this study, looking at a listeria-based HPV-targeted immunotherapy. And so again, I think what we're seeing with cervical cancer in women that develop this disease, there's an aberration in their immune system. And so if we can find ways to re-engage the immune system, we should be able to improve responses and potentially disease control. And so this was a two-stage design in women that were receiving second or third line therapy. And what we saw is that about 40% or so of patients were alive at 12 months, which was pretty exciting. There was one CR in this population. About 30% of patients had stable disease, although unfortunately, because of a couple of different reasons, about 20% of the population was not evaluable. So it's a little bit challenging to incorporate this data in terms of how we should proceed with evaluating this agent. But certainly when we see CRs after 2 lines of therapy or 3 lines of therapy, I think we all get excited about that for what is generally a chemo-resistant disease. So Dr. Slomovitz presented this data, again, looking at 2 distinct immunotherapy approaches with durvalumab, as well as the Axel compound in recurrent or persistent or metastatic cervical cancer. This was a randomized trial looking at monotherapy versus combination. And again, a relatively small trial with just over 50 patients that were included. The overall response rates were around 10% or so, which again is kind of consistent with what we've seen historically. But we did see also a large proportion of patients, both in the single agent and the combination with stable disease, which for many of these patients, in fact, can be quite meaningful. And again, looking at the Kaplan-Meier curves, what we see is that the immunotherapy, durva by itself, appears to do a little bit better from the combination. Although again, these are really small data and should be taken with a grain of salt. And so we're going to transition into a case, which unfortunately, I think we all too often see. So this was a 55-year-old woman that unfortunately presented with locally advanced disease. She was treated with standard chemoradiation therapy. Her post-treatment PET CT scan was negative, which was quite exciting. We were very reassured there, but unfortunately presented about a year later with evidence of recurrence with retroperitoneal adenopathy. And again, based on the GOG 240 data, and as listed in the NCCN, I think most of us would treat with cytotoxic chemotherapy and bevacizumab, which this patient received. She initially responded, and then unfortunately, following her 6th cycle was noted to have evidence of progression. And so the question that we all have to face in clinical practice is, what would we recommend for her now? I think, like many of us, we would look at the use of immunotherapy in the absence of a clinical trial. Knowing Dr. Duska, she's going to tell us clinical trial is an option we can't choose here. But I think
I'm not going to tell you that.
Oh, wonderful!
I would vote for a clinical trial. I think we would all prefer to put this lady on a study, but assuming we don't have one.
Yeah. So in the absence of a clinical trial, I think what most of us would look at would be whether or not we could get her pembrolizumab based on her PD-L1 status. And so with that, most of us would send NGS to get that information, in addition to other potential targeted therapy options. And so
Dr. Leaf, let me just interrupt you. What about folks who can do PD-L1 immunohistochemistry in-house?
Yeah, no,
that would definitely be an option.
That would definitely be an option. And so although we have been pretty successful in our institution with getting HER2 for endometrial cancer, it's been a little more challenging for our pathologists to be wanting to add all this additional ancillary pathologic testing. But it's a great point that it is available in many centers.
And we would expect the majority of patients, based on the CPS score that was used in the Keynote study, to be positive for PD-L1 in this setting.
Yeah. And so although the response rates are low, I think many of us assume that these response rates can be quite durable. And in that regard, it seems like that immunotherapy would be a preferred treatment option.
Dr. Weston, any thoughts for this patient other than clinical trial?
Yeah, I mean, I think if we're fortunate enough to be able to do the PD-L1 testing in-house, and so, but we generally try to do NGS sequencing pretty soon, because the expectation is that in the patients that have the durable responses, obviously that's an awesome opportunity. And we all have those patients. I have a patient that's going on 24 months and you're just so excited, but the majority of patients either don't have, the expression, or if they do, they don't have as much of a durable response as you want. And so we're always trying to kind of plan for what's next. I think we're all very excited about some of the kind of newer, not more novel immunotherapies like TILs, like tumor infiltrating lymphocyte infusions, and CAR T therapy. We've been very, very excited about that. And so I'm always eager to try to get these young patients that have reasonable performance statuses on those types of trials.
Agreed.
I completely echo both of y'all's thoughts here. What we're seeing with immunotherapy, NOS, and cervical cancer is that while the complete response rates can be pretty low, those really can be durable. With TILs, we see some pretty exciting data there with long-term disease control. And I think it's really going to be incumbent upon us to determine, which patients are going to need which therapy. It's certainly possible that, a super responder would respond to any of the immunotherapies, but we might be able to tease out some of these details where we can say, oh, a checkpoint here, or perhaps alternative immunotherapy there.
Ideally, we prevent all of these by preventative immunization.
Oh, yes.
Oh, yeah.
This is the elephant in the room, is that, seeing these cases is heartbreaking, because
it is heartbreaking.
It could be prevented with the vaccine and even, regular examinations, not always, but definitely reduced significantly.
Yeah, and we clearly have very good data looking at the impact of really what are suboptimal immunization rates currently in the United States. That even with our relatively poor immunization rates, that we are seeing a decrease in pre-invasive disease related to the HPV types that we're vaccinating against. So that clearly is showing us real-world information that if we can vaccinate, even just a little bit more, we're likely going to further decrease not only pre-invasive disease, but certainly more importantly for so many reasons, not the least of which is, cost, but also years lost. Unfortunately, many of these patients that come in, are young women, and we're not able to control their disease. And that's really a shame from a societal standpoint.
Completely agree. All right, we're going to move on to audience Q&A. And here's the first question, and I think we already answered this question.
Yeah, I mean, I think as far as the insurance question pieces, I think that hopefully as we garner more and more data from these clinical trials, it's going to help us to really determine how we can use these types of tests for selection. And then that's going to strengthen our ability to get the test paid for. But I think that these patients have so few options once they get out of first and second line therapy. And we're seeing more and more, tissue agnostic approvals happening. Like, for example, larotrectinib for the NTRK fusion. Yeah. So as that grows on and on, we can extrapolate that to our tumor types, which, we may not have an actual companion diagnostic for. So I'm hopeful that will continue to happen, for endometrial cancer.
I think the
Hope
other
is
thing,
a good thing.
yeah, I think the other thing that we've seen, Shannon, is that, again, NCCN guidelines note that the preferred approach is for a clinical trial. And for many of these clinical trials, you have to have that information. And so in discussions with insurers, for some, that's a fairly moving argument that, you're right, that if we're saying that NCCN guidelines should be followed and we're putting patients or offering patients a clinical trial, that we need to have that information in order to know which clinical trial they might be eligible for.
I like that argument. That's a good argument. All right, we didn't really talk about Poli mutations. I'll remind you all the way back at the beginning when we looked at the TCGA data, and the Poli mutations were all the way over on the left-hand side of the slide. And we do know from several studies that Poli mutations seem to be a marker for better prognosis. What do you guys think about the idea of not giving adjuvant therapy potentially to a patient you might choose to or traditionally recommend therapy for, but know has a Poli mutation?
Yeah, this is a tricky question because all of those studies didn't really take adjuvant therapy into account. So we know the population does better, but do they do better because they respond better to treatment, or can we actually defer treatment? I think PORTEC-4 is starting to explore this, where they're teasing out the patients based on their TCGA group and then, utilizing therapy based on that. The other point about this is Poli would seem to respond better to immunotherapy. There's reasons to believe that would be sensitive. So perhaps instead of doing kind of standard radiotherapy, you would instead utilize a checkpoint inhibitor in that population. So I think we have to gain a little bit more information around that to help us really truly make that decision.
Dr. Leaf, do you agree that the molecular classification is ultimately going to replace the way we traditionally think about endometrial cancer?
I really hope that it does, Linda. Just, if we look at endometrial cancer, I think we all have this frustration that with our most common cancer, we still don't necessarily know what the best adjuvant therapies are for many of these patients. Mm-hmm. And again, we've looked at, various approaches, and it is important to note that we've done clinical trials to really try to advance the field. But if you go from really the early work by the GOG, those patients included women that had advanced primary disease, recurrent disease, prior radiotherapy, radiotherapy naive. So it was really challenging to figure out what the best options are. It has been exciting to see trials published within the last couple of years trying to find better therapy options. But hopefully, similar to what's done in breast cancer, what we might be able to do, rather than just using these traditional pathologic risk factors, is actually look at this molecular information. Because again, if we know that patients with perhaps, Poli do not need adjuvant therapy, even though we would traditionally give it to them. So imagine a woman, that had a 1B endometrial cancer that was had deep myoinvasion, where we would traditionally look at adjuvant therapy. If we had clinical trial data combined with their molecular signature that says these patients are going to do great, we might be able to withhold that. On the other hand, if we can identify the patients at higher risk of recurrence that we would traditionally observe, and I think we all have those patients, a 1A, grade 1, minimal myoinvasion, no LVSI, you're really excited, she's excited, and then they have recurrence a year later. Those are the patients perhaps we can also identify that previously we would have withheld therapy for, and now we're going to recommend it. And I think the breast cancer group has really done a great job looking at some of their ancillary testing to optimize treatment outcomes.
I also find it reassuring that the molecular classification tends to be more reproducible and less dependent on an individual pathologist reading a slide. So I find that very reassuring.
No, that's a great point. That's a great point. we all, I think, have these cases which can be challenging, and you're
Yeah.
having to consider, do I go to an expert pathologist? Whereas some of these other tests, as you noted, Linda, are certainly relatively straightforward, almost binary, present,
Right,
absent.
exactly. Yep. So here's our last question, and we've kind of already touched on this several times, but it seems, based on the data that you both showed, that some of these new therapies not only have pretty remarkable response rates, but also perhaps have higher response rates in those women who have not had prior chemotherapy. And also, those response rates in some cases are better than what we would see with chemotherapy. So, obviously, we need the studies, the phase 3 randomized trials to really make the determination. But what do you guys think about the future of frontline treatments that do not include chemotherapy, either in endometrial or cervical cancer?
Yeah, I mean, I think it's going to be interesting. I think we've got two different kind of directions that are being explored. You've definitely got this whole direction of adding stuff to chemo, of which I'm a part of, where we're kind of taking the immune and adding it to the chemotherapy, perhaps doing other things in maintenance, very similar to what we've done in ovarian cancer. And I do think that that's a reasonable option, and it'll be very interesting to see how those trials read out. But, the data around the immunotherapy combinations, lenvatinib and pembrolizumab, even everolimus and letrozole, looked really great in the patients with no prior chemotherapy. And so could you, in fact, start with a non-chemotherapy option and then consider chemotherapy down the line? I think it's going to be about sequencing. And if we can find any way to bring it back to the NGS, but to molecularly stratify these patients, obviously MSI has been a huge opportunity, but if there's another way to potentially select, okay, this patient really needs chemotherapy first, or this patient would benefit from, one of these immune or targeted therapy combinations, I think that would be really exciting.
Dr. Leith, we've got a couple minutes left. Do you want to run us through this slide? These are examples of phase 3 trials assessing immunotherapy combinations in cervix cancer.
Yeah, so I think, as Dr. Weston noted, it's going to be really exciting to figure out what the best sequence is in many of these situations. It could be a combination therapy. It could be immunotherapy alone. Again, Keynote 826 in the first row is looking at combining pembrolizumab with chemotherapy versus chemotherapy alone. Again, that is a placebo-controlled trial, so that's going to be exciting to determine if it's combination therapy. Although with the previous question, it may be more of a sequential issue where immunotherapy perhaps may precede it. Nonetheless, in the Empower Cervical 1 GOG 3016, which I think has recently completed accrual, looking at, again, immunotherapy versus investigator's choice chemotherapy. And so hopefully we'll have a readout relatively soon. And then looking at the last couple of chemotherapy and immunotherapy trials, again, what we're trying to figure out, much as you evaluated in your trial, Dr. Duska, is can we combine, immunotherapy with primary chemoradiation therapy, and what's that going to do? Certainly, if we see, an improvement in prolonged disease cure, then what we might even see is that the immunotherapy question jumps the whole recurrent setting and goes to upfront therapy. And so that rather than trying to figure out, is it chemotherapy, is it immunotherapy, is it combinations, is it sequential, it might be that it's immunotherapy with primary chemoradiation, and then perhaps, again, identifying women that have surgically managed disease that might be at higher risk of recurrence. What's going to be the ideal therapy there? That's traditionally been postoperative radiation therapy alone or with chemotherapy. Perhaps those are patients that could benefit from, immunotherapy approaches. Again, we don't have any of those ongoing trials, but I think that's perhaps where, the science might take us.
And Dr. Weston, this is a sampling of ongoing phase 3 trials in advanced and recurrent endometrial cancer.
Yeah, I think you'll see there's quite a bit of the studies that are combining the standard paclitaxel and carboplatin with a given PD-1 or PD-L1 inhibitor. You can see here the Ruby study, which is exploring the chemotherapy plus or minus dostarlimab, the ATTEND study, which is looking at the same chemotherapy with atezolizumab. The DUO-E study, which I am thankful to be one of the PIs for, is looking at chemotherapy plus or minus durvalumab. And that study is a little different in that it also includes the opportunity for PARP inhibitor maintenance with olaparib. So it has 3 different arms. The LEAP study is the study I referenced earlier that is looking at chemotherapy versus lenvatinib and pembrolizumab. And then the Keynote 775 study, which is in a second-line setting, that's looking at physician's choice chemotherapy compared to lenvatinib and pembrolizumab. So really a number of different studies that are looking to kind of push chemotherapy alone out of either the front line or second line, and instead either add something or switch something entirely. So it'll be very exciting as those read out over the next few years.
We should have a lot to talk about next year, hopefully.
Yes.
So we've heard a lot of really exciting and interesting data, and I think the future is looking bright as we think about ways to improve the outcomes for the patients we've been talking about. We know that they have limited treatment options after first-line therapy. We also know that first-line therapy is not perfect and that there may be a better option in the first line. But in any case, we have a high unmet need here. And you've heard some of the research that's ongoing that hopefully will change the future for endometrial and cervical cancer. Single agent immunotherapy has shown success in both disease states, but immunotherapy combination approaches are looking really exciting. And particularly for cervical cancer, but also for endometrial cancer, there are new emerging therapy options on the horizon. So those are our take homes for tonight. And I want to thank very much my colleagues, Dr. Western and Dr. Leith. It was absolutely a pleasure to do this with you. I agree it would have been much more fun to do it in person.
This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education.